Good morning, everyone. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about Partogram or Partograph. So what we wanted to discuss today? The history of Partograph, the Friedman curve, why using Partogram, the definition of Partograph, the component of Partogram, recording the condition of the mother on Partogram, recording the condition of the fetus on Partogram, and recording the progressive labor, which is very important on Partogram, and advantages and limitations of Partogram. And on this picture, you can see the paper of Partograph. So the history began when Philippot designed Partograph in 1971 in Harare in Zimbabwe. He was inspired by Friedman's cervical graph. Friedman, the first obstetrician who described the progress of labor graphically, and did the Friedman curve. And this worked over the last 50 years. Then the WHO published the Partograph in 1994 and was called Composite 1, and WHO modified Partograph in 2000, was introduced by removing the latent phase and considering the beginning of active phase at 4 cm dilatation of the cervix instead of 3, and the other minor changes like 2 square in 1 hour instead of 1 square. And the Partogram has shown to reduce the maternal and fetal mortality and morbidity. This is the difference between composite Partograph in 1994 and the modified Partograph in 2000. Both of them designed by WHO and worldwide distributed. Of course, the modified Partograph proved to be more effective and more efficient and reduced more the maternal and fetal morbidity and decreased the rate of cesarean section. All these advantage in modified Partograph over the composite Partograph. Okay, so let us see from this picture the difference. In the old one, there is latent phase here, 8 hours, while in the modified Partograph, latent phase is not present at all. So this Partograph starts with active phase immediately. Okay? Another difference is that the active phase here started from 4 cm dilatation of the cervix. The active phase here started from 3 cm dilatation of the cervix. Okay? Other minor changes like this square 1 hour and this square divided into 2 small squares, and both of this small square is considered 1 hour. Okay? So what about Friedman curve, which was published in 1954? Friedman curve divides the stages of labor into stage 1, stage 2, as we know. Stage 1 divided into latent phase and the active phase. Latent phase starts from the true labor pain till 3 cm dilatation of the cervix. Then the active phase starts from 3 cm dilatation of the cervix up to 10 cm. And he divides the active phase into 3 parts: acceleration phase, maximum slope phase and deceleration phase. Okay? Okay. But nowadays, with modified Partograph of WHO, the active phase starts from 4 centimeter, not from 3 centimeter as in Friedman curve. Okay? So, the latent phase in modified Partogram start with from true liver pain till 4 centimeter, and the active phase start from 4 centimeter to 10 centimeter. As you see, it is sigmoid shape, and this Friedman curve was underused all over the world for a long time in the past 50 years. Okay, so we are using Partogram to reduce the fetal mortality and the morbidity and the maternal morbidity. And if you know that about 97% of all reported neonatal deaths occur in less developed countries, and a majority of these deaths are direct consequence of labor complications, so we are in need for a specific or a special tool to be used and to be published and worldwide distributed to minimize this fetal morbidity and the mortality and the maternal morbidity. So we find the solution in the Partogram, which is a simple tool and has shown its utility in detecting the labor abnormalities and in directing timely intervention. So there is intervention at the suitable time, so you can reduce the morbidity and the mortality. So Partogram is a simple and useful tool in monitoring the progress of labor and graphically recording it. Actually, Partograph is a Greek word, means labor curve, means labor curve. So Partograph is used to distinguish normal labor from abnormal one, and will record the condition of the mother and the condition of the fetus and the progress of labor on this Partogram. So the component of Partogram, as you see here, mother information, fetal well-being, maternal well-being, labor progress, and medication used during labor. So look to the component of Partogram while you are looking to this picture. The top of the paper here is information about the mother, the name, the age, the gravidity, the parity, the hospital number, and date and the time of admission, and the time of rupture of membrane. This upper part belongs to mother information. Then next to it, parameters related to fetal well-being, including the fetal heart rate, this one, and character of liquor, this one. Is it, if the membrane is intact, we said I. If ruptured, is it clear? C, letter C for clear, or meconium stained, letter M for meconium, or B for bloody meconium. Then next to it, the molding of the head. And we know that molding means approximation of the two parietal bone, so closing the space between the bone in the sagittal suture, or overlapping of one bone over the other, which may be reversible or irreversible. So it is three category, 1, 2, 3. So if you found molding, you will say M1 or M2 or M3 according to the severity of molding in this part will be written. Okay, so fetal heart rate, liquor amnii, is it clear or meconium or blood stain? Then molding, grade 1 or 2 or 3, or no molding or zero. Then about labor progress. This area for labor progress, including the following: the dilatation of the cervix and its effacement, the descent of the head, this is for dilatation, and the mark X for the dilatation, and descent of the head, and letter O for descent as a marking, okay? And uterine contraction here, in this part, how many contractions per 10 minutes and its duration. Then in this area of partogram, the medication, before the medication used, oxytocin, if it is used, how many drops per minute and how many units used, infusion. Then this area for medication, like analgesia, like sedative, any drugs used. Then this area for maternal well-being include the blood pressure between these two arrows, systolic and diastolic, and the fetal heart rate as a dot here. Maternal heart rate or maternal pulse here as a dot here, and systolic and diastolic blood pressure in this arrow, and character of the urine as regard the volume of the urine, presence of sugar, acetone, or albuminuria. Okay. Also, for maternal well-being, the temperature will be recorded also. So, again, the top of the page or the paper for mother information. Then next to it, the fetal well-being, fetal heart rate, character of liquor and the molding of the head. Then in this area, the progress of labor as regards cervical dilatation and effacement and descent of the head and uterine contractions. Uterine contraction this area. Then any oxytocin given, dose, and dose per unit, okay, and how many drops per minute. Then other medications given here in this area. Then the maternal will be including the pulse, the blood pressure, the temperature, and lastly the criteria of urine, its volume, presence of proteinuria or glucosuria or acetone in this part. This is a component of the partogram. This is the paper of Partogram and should be present on all obstetric units in any center all over the world, especially in less developed countries. Okay? Because you should monitor the labor, you should monitor the maternal parameter and the fetal parameter, and it is valuable in reducing the maternal and the fetal morbidity and mortality. This is an example of a case. As you see here, this is the data about the mother. Then here is the fetal heart rate within normal here, ranging between 120 up to 160. Then here is the cervical dilatation. As you see, this X mark, then no progress in cervical dilatation for 2 hours. Then progress happened and continued till reaching full dilatation of the cervix. Of course, to say the progress is normal should be to the left of the alert line, as we will see later on. Okay, but here, passing through the alert line and about to reach the action line, then with corrective measures, the reaches the full dilatation and again to the left of the action line. As you see here, number of contractions per 10 minutes, and here is the maternal parameter, the pulse, blood pressure, temperature, and here the volume and character of the urine. Okay, this is an example of partogram, and here the result at the end was spontaneous vaginal delivery at 20, resulting in live male infant weighing 2.6 gram, 2.6 kilogram. Okay, so this is an example of for the partogram for one case. So let us start the details about partogram. First, we said mother information, name, gravidity, parity, hospital number, date and the time of admission, and the time of rupture membrane. Okay, so let us continue with the recording of the mother or maternal well-being. The maternal pulse, blood pressure, temperature are recorded in the partogram, and the urinary data, as we said, the volume, presence of glucose, albuminuria or acetone, all of these represented here in the partogram in urine details of the mother. Here is the temperature, here is the pulse and the blood pressure between two arrows, systole and the diastole, and these dots represent the maternal pulse. Okay, these dots connected together related to maternal pulse and the changes that happen during labor. Okay, this part of the partogram is for maternal well-being. Let us shift to fetal well-being. As you see in this picture, this is the fetal heart rate. Okay, here started 140, then dropped to 130, and so on. You will mark accordingly, and it is measured every 15 minutes. Okay, during labor. And we know the normal between 110 and 160. Okay. What else as regard the basal fetal heart rate? If there is any deceleration, especially delayed deceleration, you should record it. What about liquor finding, the amniotic fluid? What about the amniotic fluid? Is the amniotic membrane intact? We will write I. We will write I in this partition. If it is ruptured and the amniotic fluid is clear, we will write C. C for clear. If it is meconium stained, we will write M, like this. If it is bloody stained, we will write B for bloody. Okay? So this part for amniotic fluid. What about the molding in this area? If there is no molding, we will say 0. If there is molding, we will say, is it 1, grade 1, or 2, or 3? Here, 1. At the start of the active stage of labor, it was 1, then became 2 after certain time, then became 3. So, this is as regard the fetal well-being, fetal heart rate and presence or absence of any deceleration, Lycor finding here, then molding here. What about the progressive labor, which is very important? Okay, to understand it, you should look to this picture, this area of this picture, and you will find that this is for cervical dilatation in centimeter, this vertical arm, and this is for the duration of the time. Okay? Okay. We said the active phase start from 4 centimeter and the end and at 10 centimeter. Okay. So we have here in this picture two lines, alert line and the action line. Actually, when you see patient in active stage of labor, first draw the alert line and the action line immediately, starting from 4 here, and consider as if the cervix dilate 1 centimeter per hour, so continue the line up to 10 centimeter like that. Then, in a distance of 4 hours, and to the right of this alert line, you will draw a parallel line called action line. Okay? This is before you record any parameter as regard cervical dilatation or descent of the head. Okay? Okay. So we will draw the alert line and the action line, and we know now how to draw it. Okay? Normally, the cervical dilatation should be, in its progress, should be to the left side of the alert line in this area. So if it is started 4 centimeter, after 2 hours, it would be, for example, 6 centimeter to the left, and so on, so on, so till reaching 10 centimeter, and the normal is to be to the left of the alert line. But if there is problem in the progress of cervical dilatation, it will pass or cut the alert line and pass in the area between the alert and the action line. This should be alarm for you, okay, that there may be something wrong because the progress of cervical dilatation is not going very well. So if there is weakness in uterine contraction, you may rupture the membrane and may use oxytocin infusion to cause more stronger uterine contraction. Then, if labor progress very well, it will go again to the left side of the alert line or in the same area between the alert and action line, but not passing to the action line. Okay, till reaching 10 centimeter and delivery. But if you did all measures and the progress pass through, there is no more progress in cervical dilatation or slowly progress, then the line of progressive cervical dilatation cross the action line. This is a very risky and denoting a problem, and they may need immediate intervention with cesarean section, okay, because you may have arrest in cervical dilatation or protracted cervical dilatation despite the presence of strong uterine contraction and efficient uterine contraction, so you may need cesarean section. So this alert line and the action line is to make you aware about any coming problem. So We should discover the problem early if there is delay or in the progress of cervical dilatation, so you can interfere early and prevent complication to the mother or to the fetus. Okay? Okay. So the active phase abnormalities are described as protraction disorder, means slower than normal progress, or arrest disorder, like complete cessation of progress. There is no progress. Okay? Okay. Also, the problem may be in the descent of the fetal head. This area representing the descent. Okay? By palpating the fetal head parts through the abdomen, 5/5 of the head can be felt, or 3 or 4/5, or 3/5, or 2/5, or 1/5, or nothing of the head can be palpated through the abdomen. So the head is deeply engaged. The head is engaged if 2/5 or less of the head can be palpated through the abdomen. Or if you did BV and the lowermost part of the presenting part at the level of ischial spine, what's called station 0, or becoming 1 centimeter down, so +1 or +2 or +3 and so on. All this engaged head. Also, the descent of the head may be protracted or arrested. So let us look to this picture. We are recording the cervical dilatation on the partogram to see the progress. Is it very well progress, or there is problem as regard the progress of cervical dilatation? And we will mark X for cervical dilatation and the O, letter O, for descent of the head. So if you found X, this means for cervical dilatation. O for descent of the head. Okay. You will do BV and measure the cervical dilatation. Okay. Of course, we started the active phase from 4 centimeter in modified WHO Partograph. Then every 2 hours, put the mark of denoting the progress of cervical dilatation. Okay? Okay. And the descent of the fetal head. As you see here, 3/5 of the head can be palpated, so the head not yet engaged. 2/5 of the head is palpated, so the head becoming engaging. Then the head is completely engaged. Nothing of the head can be palpated at station at 0 level here. Some describe the descent in a different way, not through the abdominal examination. Rule of fifths. This is the abdominal examination and the rule of fifths. How many parts of the head can be felt abdominally? And starting from number 5 here, and this go down means the head is engaged. Okay, or engaging. So how many fifths of the head palpated through the abdomen, and put the mark letter O accordingly and write the time here. Okay? Okay. Some use another way by BV examination and using delay method for station 0 at level 3, but this is station 0, then +1, +2, +3, and above station 0, -1, -2, -3, and so on. Either of them can be used for the center of the head. Okay? In this picture, what about the progress of cervical dilatation? Is it normal? Yes, it is normal. Why? Because all the progress to the left of the alert line. till reaching 10 centimeters. So it is doing very well. What about the descent of the head? Is it okay or not? Yes, there is progressive descent of the fetal head till becomes deeply engaged. So it is very well in this partogram. What about the other picture here? The other picture here locked to the cervical dilatation in the active phase, which started from 4 centimeter here. What about the progress? After 4 hours, reaching 8 centimeter. Then, so there were a progress, but slowly progressing. Okay. Then that's why the mark of dilatation pass through the alert line and become in the distance between alert and the action line. We said the normal is to be to the left of the alert line. But now we have an alarm for cervical dilatation because it lies in the distance between alert and action. Then at this point, at 4 hours from the first examination, after another 2 hours, we found no progress in cervical dilatation. And the line or the curve crossed the action line. This is dangerous. This is dangerous. Okay? And it means there is a problem in the progress of labor, maybe cephalopelvic disproportion, contracted pelvis. There is something wrong here. Okay? Okay. So you shouldn't reach to the right side of the action line. And if you reach that, know that the delivery will be difficult and the knee emergency with cesarean section, operative delivery. Okay? So you should interfere at this point between alert and action line by doing amniotomy, by oxytocin infusion to cause strong, efficient uterine contraction, and so on. If there is improvement, the dilatation will pass to the left side of the alert line and reaching 10 centimeter. If there is no improvement, like in this case, there is arrest in dilatation here. What about descent of the head in this partogram? In this partogram, descent of the head, how many parts of the head felt through the abdomen? 3/5 of the head. So the head is not engaged. After 2 hours, the same. After another 2 hours, the same. After another 2 hours, the same. So this is called arrest of descent. So I have arrest the cervical dilatation in this area of the curve of cervix, cervical dilatation, and the arrest of descent of the head. So this case need emergency cesarean section. Okay? Okay. So we have in two pictures here. This partograph with normal progress of labor and spontaneous vaginal delivery. And this partograph, abnormalities happen in the active phase as regards the cervical dilatation and the descent of the fetal head. There is arrest in cervical dilatation and the arrest of descent of the fetal head, so needs cesarean section. This is how the partogram differentiate between normal labor and the abnormal one. So the active phase abnormalities may be, as we said, protracted cervical dilatation. If the progress less than 1.2 centimeter in hour, in nullibara or 1.5 centimeter per hour in multibara. Or arrest of cervical dilatation if 2 hours with no cervical dilatation. Or there may be protraction of descent of the head less than 1 centimeter per hour in nullibara or 2 centimeter in multibara. Or there is arrest of descent if there is no descent for 1 hour. And as you see in this partogram, I described this before. Log to the picture on the right side, log to the cervical dilatation, and the log to the descent of the head. And the comment, this is this X mark for cervical dilatation. The progress is slow, so pass through between the alert and the action line in spite of being to the left. Then slowly progressing, but and reaching the action line, so alarming that there is a problem. Maybe need strong uterine contraction, maybe you are in need for oxytocin infusion, and the reaching the 10 centimeter by crossing the action line. This is dangerous. Crossing to the right of the action line is dangerous, denoting a problem. What about the descent of the head? Lock to the descent of the head. First, there is slow descent but not engaged, and then arrest of the descent. No more descent. Okay, so this is arrest, an example of arrest of descent of the baby or the head, and protracted cervical dilatation. Slowly progressing, protracted. So this is an example for the active phase abnormalities. So if we wanted to record the effacement, we can do it on the partogram by drawing a line 3 centimeter according to the length of the cervix. We said 3 centimeter, so 3 squares here, 3 centimeter. Or 2 centimeter, 2 square here, or 1 centimeter, 1 square here. Or you can use the percentage of effacement, like 25% effacement, you write it inside the square, or 50% effacement, or 80% effacement, or 100% effacement. This is as regard the effacement of the cervix. You can record it on the partogram also. Okay, what about the frequency of the uterine contraction? The frequency of the uterine contraction, the efficient one should be 3 contractions per 10 minutes. So you will mark it here, this square. This is the area, the number of contraction per 10 minutes. The number of contraction, 1 or 2 or 3 or 4. Here is 1, here is 2, here is 3. Okay? And the duration of the contraction, is it up to 20 seconds, or from 20 to 40 seconds, or from 40 to 60 seconds or more? How can I differentiate between them according to the duration of the uterine contraction? By using the following. You will mark dots if it is 20 seconds or less, or lines if it is 20 to 40 seconds, or color the squares if it is from 40 to 60 seconds or more. Okay, so it is very easy to know the duration of uterine contraction and its frequency. Okay, as you see here, another picture here, you can see 2 contractions, 3 contractions, 4 contractions, 5 contractions. And what is the duration of the contraction? How you know it? Okay, it is easy, yes, by the marks here. If it is, the block is stippled as here, so this means less than 20 seconds. Or stride like this one, stride, so it is between 20 to 40 seconds. Or it is colored as here. So it is from 40 to 60 seconds or more. Okay. So what is very important partogram is a timely decision. And your decision could be transfer the woman in labor from the peripheral unit to central unit. I mean hospital with facility for cesarean section available. Okay. Or the decision may be augmentation of labor with oxytocin infusion after rupture of membrane, or maybe termination of labor by cesarean section. So you talk the decision according to your record on the Partograph. Okay, then you assess and manage, and after each examination, you should record on the Partogram and in what's called maternity case record. All management in labor must be also recorded on the Partogram and the end result. Also, you should record the time on the Partogram at each examination. Okay. Okay. The time should also be written whenever an observation is recorded, medication is given, and assessment is made or management is altered. Okay, recording the medication is important. Yes, you record the medication here, as you see. The name, the dose of the drug, the time the drug was given, the type of intravenous fluid, the time the intravenous fluid was started, the rate of administration, and the amount of IV fluid given. Okay. So, what are the advantages and the limitations of the Partograph? According to the advantages, Partograph provides information on a single sheet of paper. This is very important. Early prediction of deviation from normal progress of labor. Improvement in maternal morbidity, perinatal morbidity, and mortality. Also may reduce the cesarean section rate, specifically after using modified WHO Partograph. But there is some limitations for Partograph. It requires a skilled healthcare worker who can fill and interpret the Partograph. Some studies shown that there is no evidence that Partograph use is detrimental to outcomes. Often paper Partograph and the equipment required to complete it are unavailable in low resource settings. According to some recent literature, cervical dilatation over time is a poor predictor of severe adverse birth outcome. Despite the case of training, investments, implementation rates, and the capacity to correctly use the Partograph are very low. So these are some limitation, and there is up till now controversy about the how important is the Partograph, because some believe we should change this method of recording the progress of labor to another one more simple and easy, and it can be done uh, in easy manner and in every part of the world. Okay, and doesn't need much skill. So some believe that, but in my opinion, Partograph is very important, and yes, specifically the modified one, which used from 2007 all over the world, because it actually it reduced the maternal and fetal morbidity and mortality, and reduced the incidence of cesarean section. So I found it in many articles is very effective, especially when used properly in low developed countries. It, it is doing very well. So I encourage the use of Partograph in all hospitals for the care of the mother and fetus. So look to this some example of Partograph. Can you see the fetal heart rate with the normal? What about cervical dilatation? Doesn't cross the alert line here, here reaching the 10 centimeter. What about the descent? Doing very well. So what about the uterine contraction? Is it efficient? Yes, 40 to 60 seconds and 3 contraction per 10 minutes. Here become 4 just before delivery. The result was spontaneous vaginal delivery, okay, of live female. All parameters as regard the mother pulse, blood pressure were normal, and the character of the urine were normal. So this is a partogram of a case with spontaneous vaginal delivery. Spontaneous vaginal delivery or normal labor. Another partogram. Can you see the fetal heart rate with the normal range? Clear meconium, clear amniotic fluid. No problem as regards the amniotic fluid. No molding. Dilatation of the cervix. Progressing very well, and to the left side of the alert line. This is very good. The descent of the fetal head progressing very well. Uterine contraction were efficient, more than 40 seconds, and about 3 contraction to 4 contraction per 10 minutes, and to continue for more than 40 seconds each contraction. The maternal blood pressure and the pulse was normal, and temperature. Normal characters of the urine. The end result is normal labor and spontaneous vaginal delivery of living female of average weight. This is another partogram. Another example for a case, fetal heart rate was normal. What about amniotic fluid? And amniotic fluid were intact, then ruptured. Amniotic fluid were clear. What about cervical dilatation? Cervical dilatation, there is protracted cervical dilatation, crossing the alert line, reaching the action line, then again to the left of the action line till 10 centimeter. What about the descent? Descent of the head, slowly progressing, okay. So what about the uterine contraction? Weak uterine contraction, 2 per 10 minutes, and each contraction less than 20 seconds. So is there interference to improve this? Yes, oxytocin infusion here, 10 units. How many drop per minute? 15, and increase to 30, then to 45 drop per minute until it causes strong uterine contraction, 3 uterine contraction, until reach 4 uterine contraction per 10 minutes. And each uterine contraction, we know that the normal is 3 uterine contraction, and each contraction should be more than 40 seconds. This is more than 40 seconds because it is colored. So efficient contraction cause better cervical dilatation and descent of the fetal head and spontaneous vaginal delivery. This case wasn't an easy case, difficult case of course, because it reached the action line. Although with interference with oxytocin infusion and good uterine contraction, cervical dilatation progress more better and reach 10 centimeters. So yes, vaginal delivery, but was difficult case because it crossed the alert line, should be on the left side of the alert line, and reach the action line, then again to the left side of the action line. Okay, this case was a difficult case. What about the maternal parameters? Was normal, the pulse and blood pressure, temperature, and normal character of the urine. Another case, what about the fetal heart rate pattern? At the start of the labor, it was normal, the active phase, then lowered below 100, so there is distress, fetal distress. What about amniotic fluid? Was clear, then become meconium stain here. What about cervical dilatation? Cervical dilatation slowly progressing past the alert line in the area between alert and action line, then arrest of cervical dilatation and crossing the action line. Dangerous sign. What about descent? There is no descent over the time. Every 2 hours there is no descent. So there is arrest of descent and the arrest of the cervical dilatation despite good uterine contraction, as you see here, 3 to 4 efficient uterine contraction. So this case with these parameters, fetal heart distress, meconium, arrest of cervical dilatation, arrest of descent of the head despite good uterine contraction, so it is an indication for cesarean section, of course. So this is the case with normal Partogram, progressing very well, cervical dilatation and descent of the head with good uterine contraction, with good fetal heart rate parameter, with clear amniotic fluid, with good maternal characters as regard the systolic and diastolic blood pressure and the pulse and the temperature, normal character of the volume. The end result was spontaneous vaginal delivery, and this is the end of my lecture today. Thank you. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.